And I'm an OCD Massachusetts board member. Welcome to the Les Bradford Memorial OCD Lecture Series. Tonight, Dr. Nancy Keuthen will be discussing treatment for body-focused repetitive behaviors. Dr. Nancy Keuthen is a graduate of Brown University in the clinical psychology program at Stony Brook University. Since 1986, she has been on staff at Massachusetts General Hospital and faculty at Harvard Medical School. Since 2001, she has been Associate Professor of Psychology at Harvard Medical School. She is the former director of the Cognitive Behavior Therapy Program at Mass General Hospital. Dr. Keuthen has been the chair, vice chair, and member of the Scientific Advisory Board of the Triptylmania Learning Center, and member of the Scientific Advisory Board of the International OCD Foundation. She has been a guest editor for several scientific journals and is the founding member of the International Triptylmania Research Consortium. Dr. Keuthen has made important contributions to the diagnosis, etiology, and treatment of obsessive-compulsive disorder, as well as the related disorders of trichotillomania, pathological skin picking, and body dysmorphic disorder. Her bibliography lists nearly 100 peer-reviewed publications in this field, in addition to a book, numerous chapters, educational materials, and internet-based self-help materials. Please join me in welcoming her here tonight.
So I'm going to be talking about trichotillomania, just so I know who's in the audience. Do folks mind raising their hands if they're affected by it or they have somebody that they love who's affected by trich? Okay. And are any of you professionals or are most of you consumers, shall we say? Consumers. Okay, so if the talk at some point is a little bit too technical, just speak up and ask me to explain it in a different way. I wasn't quite sure who the audience was going to be tonight. So trichotillomania, as you know, is compulsive hair pulling, and this is a disorder that's highly comorbid with OCD. We talk about that OCD spectrum, so if somebody has OCD, they have a greater likelihood of having certain other disorders, including things like trichotillomania, tics, body dysmorphic disorder. Okay, I'm going to read a case vignette for you just to try and give you a little bit of a flavor of what it's like for somebody who has trichotillomania. So this is Sandy. Sandy's a 23-year-old single female who comes in reporting increasing depression over the past several months that's coinciding with worsening of her hair pulling problem. She had been in treatment several times in the past for her depression and family issues, but never specifically for the trichotillomania. She recently saw a TV show on hair pulling and wants to now address this for the first time. She first started to pull when she was 12 years old. She recalls being instructed to pull out a hair in science class and view it under a microscope. She recounts a curious pleasure when she extracted the hair from her scalp and being fascinated by the root sheath that was attached to the hair. When she went home that night, she found herself compelled to pull out several more hairs, running her fingers over their slippery roots and even biting off the bulb at the end of the hair. Over the next few months, she pulled out so much hair in the crown of her scalp that she created a quarter-size area of depilation. Her mother questioned her about this, but she feigned ignorance. She was taken to her pediatrician, who never asked her if she pulled her hair, but simply gave her mother topical ointments to address a possible dermatologic infection. She felt ashamed that she hadn't been honest with her mother, but feared upsetting her if she told the truth. Years in school started to notice her bald spot. She increasingly found herself withdrawn socially, and at times pretended to be ill to avoid school. She tried to camouflage the hair loss with a different hairstyle and hats, but the teachers often made her remove the hat in class. She stopped running track and swimming, even though she had competed on school teams previously. She avoided sleepovers with her girlfriends, as they often spent time styling each other's hair. She found herself pulling more and more when she felt tense or stressed. She also noticed that she pulled unaware when she was studying or watching TV. During those times, she often didn't notice until she saw her desk littered with hair or her arms started to hurt. At times, it felt like she was in a trance and had no choice but to continue pulling. At some point, she realized she could pull from other body sites, including her pubic area, to lessen the hair loss from her scalp. She then pulled less from her scalp, the hair grew back, and her mother forgot about her prior hair loss. While relieved that others now didn't notice, she felt increasingly ashamed and secretive about her behavior. Not only did she feel relief upon pulling when stressed, but she also experienced gratification with the remove hairs that had odd textures. For example, wiry or kinky hairs, or those with unacceptable colors, those that were gray or black. She increasingly would get frustrated if she couldn't get an intact hair root, as she liked to run her fingers along the wet root and then bite it into little bits. At times, she stayed up late at night to sit on the bathroom counter, using tweezers and also pins to extract ingrown hairs. Her guilt around her pulling often led to even more pulling despite her fatigue, as this would soothe her. At times, she would be tired the next morning after hours of pulling and have difficulty functioning in school. Her parents took her to a psychologist in high school when her grades plummeted and she had even less interest in extracurricular activities than in the past. She saw different mental health professionals who diagnosed her with depression or screened her for learning or attention issues. No one commented on her hair thinning, even though it was apparent at times, and she was too ashamed to discuss it. She was referred for antidepressants and had family therapy, as some providers thought her mother was anxious and too controlling. Sandy tried to manage her pulling on her own by wearing band-aids on her fingers, mats on her head, and always having something to fiddle with to keep her hands occupied. At times she could go for days white-knuckling it and successfully abstain from pulling. Inevitably, though, she would relapse when upset or pull outside awareness. Thus, the cycle would repeat itself over time. After a while, she started to tell herself that she was unlikely to ever control the problem, given so many unsuccessful attempts in the past. She also started to wonder if she was really crazy, as none of her past treatment had helped to reduce her urges and pulling. In addition, she didn't know anyone else who pulled out their hair, making her feel even more isolated and alone. As her involvement in leisure and social activities decreased even further, she spent more and more time at home, allowing even more pulling to occur. Her mood consequently worsened as well, giving her decreased productivity at work from time spent pulling and less time with family and friends out of fear that they might inquire about her hair loss. I'd like to present that vignette because it really captures a lot of the different features of the phenomenology and the functional impact of the disorder. A lot of things that we're going to talk about now, the clinical presentation, the demographics, and the functional impairment that's associated with pulling. So here's a person who's obviously a scalp puller. You know, the identity is hidden, and we have the permission to show these. And here's somebody who pulls from the eyelash to the eyebrow area, and you can see particularly in the middle part of the upper and lower lids, it's very patchy. And from what you can see of the eyebrows, similarly, there's a lot of hair decollation. So in terms of the clinical presentation, people can pull from any body site. There's no part of the body that has hair that there haven't been reports in the literature of people pulling from that site. But most commonly, it's the scalp and then the eyebrows and the eyelashes. It's common, particularly over time, for people to pull from multiple sites. And what's fascinating, and it's a challenge for treatment, is that it varies from time to time. Very often people will depile one area and then they'll move on to another area. But what's tricky is people get different sensations from different parts of their body that they pull from, and those sensations actually can change over time as well. Nobody understands that. It has a waxing and a waning course, so very often we'll see that it starts, adolescence is the most common time, and then people may have a period of remission where they don't pull at all for a while. And then maybe under a stress it'll start again, and then it'll stop and it'll start again. And over time as they get older, the pulling just gets conditioned to a number of different triggers. So there are two different styles of pulling. We're going to talk a little bit more about it further in the lecture, but there's different presentations. One is more automatic and habitual, and the other is more focused, where the person is very aware of what they're doing. And it tends to be more driven by internal discomfort, by emotional upset, or even some physical discomfort. So what you see is amazing heterogeneity. And in each case, it's like a puzzle. And you're trying to figure out what the presentation is, what the triggers are, what the behavior does for the person. And it's just so critical to put these pieces together to make sure that you tailor your treatment specifically to that individual. You know, I think more so than a lot of the other spectrum disorders that I treat, and I treat them all, TRIC is, it really requires a good assessment. It really mandates that the person figure out the pattern well enough that we just don't do like a cookbook approach, because if you go that avenue, you're not going to be that successful. Okay, so the automatic pulling, one of those two styles that I referred to, that's when somebody is pulling out of awareness. So very often they're engaged in some kind of sedentary activity. They can be watching television, they can be reading, they can be on the computer, they can be in the car. And one or both of their hands is free, their mind is focused elsewhere, and their hand just wanders up and starts to play with their hair, and they're twisting and turning. And for a lot of people, there's specific hairs that are perceived as abnormal, hairs that they feel have to go. And in the course of their travels, when they're manipulating their hair, they may find those hairs and start to pull. So very often the awareness only comes in once they're midway in this process. So it doesn't feel like a conscious choice to them. And very often it's in a context in which there's limited sensory stimulation. So their hands are looking for something to do. They're bored. They're bored in many ways, and this becomes a focus for them. This tends not to result in that much hair loss. It's a hair here, a hair there. In contrast to the focused pulling, which is when people are very aware of what they're doing. They generally experience the urge first, and it's a decision that I'm going to elevate my hand to whatever the body site is that I pull hair from, and that I'm going to pull. And what happens is that this pulling behavior gets reinforced because a number of different things can happen. So when you have an urge and you pull, it reduces that urge. So that internal discomfort that's associated with the urge, that goes down. If it's triggered by a thought, if someone has a worried thought, when people are pulling and they're busy trying to find those hairs to pull, they get distracted from the other thoughts. So it reduces the worry and any somatic symptoms or sensations that may be associated to their worry. And the same thing with anxiety. When the person engages in the pulling, it reduces the anxiety that they're feeling. So in terms of demographics, different people always cite different rates of how prevalent things are, and it's a function of how conservative or liberal you are in your definition of the problem, right? So this is probably the prevalence rate that's most often quoted, from about 0.6% up until about 4%, and it varies depending upon whether you're male or female. It's much more common in females, right? What we say that primarily a female problem, the female to male ratio is 8 to 11 to 1. So for every one male, there's 8 to 11 women that have this problem. And it also depends upon, when you define the problem, whether or not you require that they experience this urge prior to the behavior, and that they can endorse that they feel relief, gratification, or pleasure after it. But it's a fairly common problem. I mean, OCD is in around the 2% range. So if you're going with the higher prevalence rate, this is a problem that a lot of people have. And if you think about it, if you went with the 4% rate, that's 1 out of every 25 people. So if we all think about how many people we know, 1 out of every 25 of those people has this issue. Now that's not to say that they wear it on their sleeve and it's apparent. A lot of people are very good at camouflaging the problem. They pull their hair in a distributed way, so there's no patchiness or baldness. They pull in sites that are not visible, from legs or groin area. Men can attribute it to male pattern baldness. Men can pull from a bearded shave, so there's no provocation. But all of you know somebody who's a puller. You may not know who they are, but you all know people that pull their hair. So in terms of onset, most generally it's in adolescence around puberty, but you will see in some young, very young infants that they suck their thumb. So the thumb from one hand is in the mouth, and then they're twirling with the other. And some of them progress to actually pull their hair out. It may be a little different in the infants in that it may be self-limiting and not go on to be trichotillomania as we know it when it's adolescent onset. But there are a number of infants that do this, and actually we're getting swamped with calls. I mean, now that a lot more advocacy for this disorder has been done, people finally know there's a name for it, people know that there's some clinics, and unfortunately there are not enough clinics to treat this disorder. So we get calls about easy 5 to 10 kids a week. And, when it's a child, the parents really want to get help for their child. So this is followed to the problem. Obviously, hair loss or change in how the hair looks. So when you pull on hair repetitively, it can change color, it can change texture. If the follicle is traumatized, if somebody's pulling with some force, there can be scarring inside the follicle, so it can come out in kind of a curlicue fashion. So it does change the hair. People can have pruritus, which is just an itchiness. There can be tissue damage that can be done. And very often people also pick at the sites that they pull from. People will say if they pick in that area, when they then pull from it, it actually feels even better. There's some heightened sensitivity. People can get infections from it. If people pull hard enough and they break the skin, I've had patients that have gotten infections from it, and particularly if they pick in conjunction with pulling. And very often those two things can go together. In severe cases, people can get systemic infections. People can get neuromuscular problems. So a lot of patients will adopt these odd postures, like if they're trying to pull from the back of their hair, they may be like sitting on the counter and have a mirror and tweezers, but just the raising of your arm repeatedly. A lot of people will say they have shoulder problems or they develop, we actually reported on carpal tunnel problems in a case series because of the repetitive motion of the hand pulling. Trichomosaurs. Anybody know trichomosaurs? Anybody want to guess? Hairballs. Just like cats, dogs, humans can get hairballs because a number of people ingest the hair after they pull it out. And in very serious cases, it can be life-threatening. So if you know somebody who pulls their hair and they ingest their hair and they have gastric upset, that should be reported to a physician. I've had a couple of patients that have had to have repeated GI surgeries to remove hairballs. Dental problems, chewing on the hair, just the repetitive mincing, you can do damage to your teeth. A lot of patients won't get medical care. A lot of patients, I've had a lot of women that when they're pregnant and they're about to deliver, they're more worried about people seeing them if they have patchy hair loss, particularly in the groin area, than they are about the pain of delivery. And just the emotional distress of knowing that you're doing something to yourself that other people don't do. And as you can imagine, it can impact your functioning. So if you have patchy hair loss, and if you style it in a way, you may be afraid to go to the beach. You may be afraid to go bike riding in the wind, or people are uncomfortable in intimate situations, and they know that somebody is going to detect this. So a lot of times people will shy away from certain activities. And if somebody pulls in a binge fashion, repetitive pulling for several hours, it certainly doesn't do a whole lot for, your academic performance or at work if you're trying to, meet deadlines, but you start to pull in a trance-like fashion. Okay, so this is a trichomosaur. So on the left, this is called Rapunzel syndrome, and this is all hair, and that's just tracking through the intestine. And on the right, this is a true case. There have been several cases in the literature of people removing hairballs that are up to 5 pounds. And this has been like a lifetime of people ingesting hair, but it basically lodges in the intestine, and it can become a nidus for infection. Okay, so comorbidity, a lot of disorders go along with this. So comorbidity just means co-occurring. So if you have trick, what's the likelihood that you're going to have a mood disorder like MDD, which is major depressive disorder, or an anxiety disorder, substance abuse, tics, eating disorders? You know, if you think about it, if you're doing this and it's upsetting you and it's limiting your functioning, it wouldn't be surprising that you would get depressed, right? So about 50% of people that have trichotillomania have lifetime major depressive disorder. I mean, that's a high number. That's 1 in 2. And a fair amount have generalized anxiety disorder, social phobia. Again, no surprise if you're unhappy with how you look, you may be uncomfortable around other people. Substance abuse issues, alcohol, drugs, 15% to 20%. Tics. Again, tics are what we call a comorbid spectrum disorder, along with OCD and trick. At one point, actually, people were wondering if trichotillomania and tics were like different manifestations of a similar common underpinning. I think we're moving away from that model now, but some people can have tics, not a whole lot, and eating disorders. Okay, so DSM-5, you folks all know what the DSM is, right? It's kind of our Bible for categorizing things. So actually, this month, May of 2013, DSM-5 is being made public. And a number of us were on some of these subcommittees to discuss how disorders and symptoms were categorized and what the criteria are. Are we organizing things in the best way? So the name is going to be slightly changed. Before it was trichotillomania, now they're going to put hair pulling disorder in parentheses. A number of us, and particularly people who have this disorder, really don't like this name, trichotillomania, because mania, smacks with craziness. Trichotillo, what does that mean, right? Actually, trick is hair and till is pull, and mania means frenzy. So, translated, it just means pulling at a rapid rate. But when we did one of those, Survey Monkey polls for our constituency, almost hands down, everybody said, ditch the name. So we proposed hair pulling disorder, and in the end, they gave us this concession of putting it in parentheses. So I guess this is progress. These machines move very slowly, as we all know. But now what's going to happen is trick was in a category of its own, and now we're going to pull together OCD and related disorders and have an obsessive compulsive and related disorders section. So to most of us that deal with these disorders, that's progress, because if you treat one of these, you probably treat the other. They have a lot of similarities in neurocircuitry, somewhat in the way that we treat them pharmacologically. So this is progress. And we're going to take out some of the criteria, the modifier words, and also 2 criteria. In the past, you had to endorse and urge prior to pulling or when attempting to resist, and to say that you experienced pleasure, relief, or gratification after pulling, and only about 80% of the patients report that. But when we did research and we compared the people that endorsed it with the people that didn't endorse it, there weren't differences in the sample. So we thought that distinction was not a good one to make. So now it's going to include more people, because we were treating all of these people in the same way. So that's DSM-5. Models for the disorder. So very early on, people thought, people are pulling, it seems repetitive, it seems driven by anxiety. It's like a compulsion. So in the very beginning, people were calling it OCD, and there's still some people that call it OCD. It's not OCD. In the very beginning, people were basically using a lot of the findings from OCD and trying to check them out for trick. And that had us go down a bunch of dead ends. I mean, there was some useful stuff there, but we realized that it's like they're kissing cousins. They overlap, but they're different. And trying to define the boundaries is a big part of what we're about now. So we know there's similarities to OCD, we know there's similarities to tic disorders, but still, increasingly, we're noting that there are more and more differences. So this is canine equivalent. What's really interesting are the ethologic models, in that for almost every animal in the animal kingdom, there's an analog to trichotillomania. So you have avian feather picking, canine equivalent here, feline alopecia, cribbing in horses, where they engage in these repetitive body-focused behaviors in which tissue is manipulated. So this is what we come from, folks. Addictions model. So this is kind of like the latest and current model that most of us are espousing to try and understand it. And, you know, I think the word addictions has some connotation and some stigma that a lot of people are like, whoa, you know, hold off here. But in the category of behavioral addictions, people talk about certain behaviors that people engage in that have similarities to addictions, to chemical addictions, using drugs, using alcohol. And if you think about it, so both with addictions and with trick, there's repeated behavior despite people knowing that there are negative consequences, right? So people that drink sometimes do things they then regret, they get into accidents. People that pull their hair, obviously there's hair loss that affects their appearance, they can have medical consequences. With trick, very often people have this appetitive urge. It's a desire to engage in this behavior, and it's akin to a craving people would have for drinking, for drugs. With trick, as well as for addictions, very often people start slowly, and there's an increasing trajectory of, you know, pulling more and more and more to get the same point. A restlessness to not engaging in behavior. So when you're working with patients with trick and you're trying to get them to not engage in behavior, they'll feel uncomfortable. And it takes a while for that to settle down and for them to figure out other ways to manage those feelings. And this is akin to withdrawal. People aren't drinking, the experience of withdrawal. So in both cases, people don't feel that they have the control over the behavior. And there can be, hedonic is pleasurable. There can be a pleasurable outcome to drinking, using drugs, pulling hair. And in all of these circumstances, people use these behaviors to regulate emotion. And that's a kind of a new trend where people are looking at a lot of clinical disorders from the perspective of affective regulation. And then there's a number of neurobiologic similarities between trick and drug addictions. And I'm not sure how much we want to go into this. This is some, you know, rather complicated stuff. But there's a certain part of the brain with reward circuitry. We know that there's some overlap between trick and drug addictions. Okay, so CBT. CBT currently is considered to be the treatment of choice for Triptylmania. And basically, the model for CBT is that we understand that hair pulling is determined by genetic variables, so that there's a role for genes, but that environmental factors also play a role through learning. So we call these diaphysis stress models. So there's a genetic predisposition, but then there's some learning experiences that results in the behaviors. And generally with CBT approaches, what's important, we don't focus as much on what started it, because very often what starts something is what maintains it. And what we focus on are the variables that are maintaining it, because that's where we can really make a difference. So the CBT model tries to identify what the contributions of all these variables are in the hair pulling behavior. And as I said earlier, it's different for every puller. And you just don't want to throw every technique that may be useful at people. You want to know, are you pulling because you're anxious? Are you pulling because your scalp itches? Are you pulling because you feel that gray hairs don't belong and you can't stand the sight of gray hairs? Are you aware that you're pulling? Are you not aware that you're pulling and you do it, and before you know it, your lap is littered with hair? All of those things are really important to tease out, because you would branch differently in your treatment as a function of what the answers to those questions are. So, you know, there's the antecedents, the things that precede the pulling, and there's the consequences, what happens after the pulling. So generally when we do an assessment, we call it a functional analysis of behavior, we would try and identify all of the antecedents. So does the person have an urge to pull because they see something that they feel is out of place, wrong? You know, a color, a texture, sometimes a length to the hair. wiry eyebrows that aren't in line? Is it a tactility? Have they been playing with their hair while they were in a sedentary situation and they felt a texture that they felt was coarse, that they didn't like, it was different from other hairs? Are the triggers more affective or emotional? Is it what they do when they're bored, what they do when they're stressed, when they're tense? Is it what they do when they celebrate? I mean, if you think of alcohol, people drink when they're stressed. People drink when they're happy. So everybody has a different pattern, and you want to know for that individual, are there certain emotions that commonly precede it? Are there certain thoughts that enable the pulling? A common one is for students, oh, I'm not going to be able to focus until I pull this hair out. It's going to bother me. I know it's there. It doesn't belong. I'll just pull it out. If someone's thinking that way, obviously, they're going to lose the hair. Is it attached to certain situations? Is it that every time they sit down on the phone and you're talking to someone, the phone is in the left hand and the right hand is pulling, or they're in the car and the right hand's on the steering wheel and the left hand is on, the door of the car, and they're leaning in and pulling. And again, most importantly, what does it do? Is it positively reinforcing? Is it negatively reinforcing? You folks know the difference between positive and negative reinforcement? No? Positive reinforcement is something that gives you a positive thing, so it would give you pleasure, give you gratification. Something that's negatively reinforcing takes away something that's negative. So if you're stressed, it de-stresses you. So you can be sure that people that engage in these behaviors, it's doing one or both of those for the individual at different times. Because otherwise, we wouldn't engage in the behavior. I don't go like this, because that doesn't do anything for me. But say maybe an autistic child or, different disorders, that may do something, depending upon the person's neurologic system, right? So you need to try and tease out what does it do for the individual. And so in treatment, what we're trying to do is to target what is maintaining it. So this is a model. We finished a randomized controlled trial a couple of years ago, and it was published last year. And this is the model that we used for treatment. So you can see in the far left column, the first thing we try to figure out, what are the triggers for the behavior for the individual? And then we look at all these intervening variables here. So say the individual was anxious to start with, and then they had another experience that made them even more anxious. The two combine to increase the likelihood that they'll have an urge and then pull. Or if there's somebody that's just very impulsive in general, right? So when you get the combination of these variables, so they have inattention. About 25% of people that have TRIP have attentional compromise, ADHD. And then it's the consequences in the far right column. So either they feel gratified or they feel pleasure by doing it, or they feel that it reduces a negative response. Okay, so I'm going to go through this fairly quickly. I think I tried to cover some of it already, but most of the time when I start with patients, everybody immediately wants to know what to do. And if I was there, I would want to know that too. But it's really important when I supervise people, and I supervise bazillion RAs, interns, fellows in this disorder, because there are not that many people that treat it, I really emphasize that you have to slow the process down, and you have to take the time to do an assessment. And you really have to insist that the person engages with you in giving you the data that you need. You can't, or the treater can't be a mind treater and know, are they somebody that primarily does binge pulling, and every 2 weeks they'll stay up all night and pull out 600 hairs? Or are they somebody that could set a clock by when they pull their hair? And they pull their hair when they're standing in front of their closet in the morning to pick out the clothes, and then they pull some hair when they're in the bathroom brushing their teeth, and they lean in and they see some eyebrows that are sticking out. We don't want to do a one-size-fits-all approach because it's not fair to the person. We want to target that treatment so that it addresses whatever their issues are. So we want to figure out what their pulling styles are. And I ask people to self-monitor. I'm a firm believer in self-monitoring for almost any disorder because most of the things that we deal with, they change over time, right? Yes? I mean, even OCD or, those of you who are here with OCD or OCD spectrum, people's presentation is not static. It changes with time. And we want to be ahead of it. We want to notice the changes. And we want to get right in there to be able to address it. So recently there are a number of psychometric instruments that have been developed, kind of similar to the Y-box, for those of you that may be similar to self-report or CD checklist. And these two at the bottom of the Milwaukee inventories, they assess the styles of both adults and children, which is a very quick way for us to get a sense of the person. So these are the things that we try to map out before we design our treatment, what's triggering it, what are the consequences. And when somebody self-monitors, not only does it help us with this functional analysis that I'm talking about, but also, it gives me a baseline, and then I can compare it and I can show it to people. And nothing beats, taking two monitoring logs and taking out the original one, which people have forgotten, and showing them change. Because very often we don't see change in ourselves, right? And it's slow, and it's so nice to say to somebody, okay, maybe you wanted to be done with this, but look, you were pulling 150 hairs a day, you're pulling 60. So that's a huge reduction in this amount of time. You've got a lot of skills, you're well on your way. And it enhances awareness. So when you monitor any behavior, you're more aware of it by the process of monitoring it. So in a funny kind of way, doing this for assessment almost has a treatment impact too, because when people monitor, very often there's what we call measurement of the activity and the behavioral frequency. So this is just a self-monitoring sheet, what we standardly use with our patients and in our studies, where we ask people every time when they have an episode to make a record, then, not at the end of the day or sitting in the waiting room before they see their therapist, where they write down, record all of these different factors so we can then crunch them and get a sense of when do you have the highest urges. Is it the end of the day when you're really tired and you have no resilience? Is that when it's the worst for you? Or is it in the morning when you're doing hygiene and you're in the bathroom the longest and there's bright lights and mirrors? You want to know all of that. So if people don't like carrying our phones around, we tell people, put it in your phone. Whatever you want to do, be creative. There's a lot of different ways to do it. Everybody now has a smartphone with a note section where they put it in there. So treatment for TRIP, traditional CBT pretty much is something that I think everybody who has TRIP should get at some point. It's been considered, as long as I've been doing it, the first-line treatment approach for a number of reasons. So there have been a number of what we call randomized controlled trials. I don't know if folks know what a randomized controlled trial is. So it's when you test a treatment and you compare it with a control condition that's generally considered to be not effective. And you want to show that with the passage of time and just contact with somebody, you're controlling for those variables in the control condition, and you want to show that your treatment is better. So there have been a number of RCTs that have compared CBT, cognitive behavioral treatment, with medication, and have shown a superiority to CBT. There's some new medications that people are looking into, and people haven't pitted CBT against those yet, so it'll be interesting to see what the results are there. Those are like $1 studies, so those studies don't happen a lot. Meta-analysis, when people combine the data for a number of different studies together, when they do that, it continues to show a superiority for CBT. And this best practices survey was something that the Triptylmania Learning Center, which is the analog to the IOCDF, this is the National Advocacy Organization for Triptylmania and skin picking that I've been involved in with it since its inception. And we put together what we call the best practices survey, and we sent it out to all the practitioners in the country that we knew treated TRIP, and we asked them what they felt was the superior approach and how often they use different approaches and how they define them, blah, 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 blah. Crunching that data, CBT came out and as well. So when I start to work with somebody doing CBT for trick, the first thing I try to work with them on is accepting their disorder, accepting what they have to do to get better. Nobody wants anybody to have any of these disorders, OCD, trick, skin picking, Tourette's, ADD, but you need a platform from which to get better, and I think the people that don't start the starting gate, they aren't settled with saying, I've got this, I accept that I have this, and that I need to do what I need to do, given what science knows now to get better. The people that are stuck in this isn't fair, maybe it's really not that bad, they never really sink their teeth into treatment. So I spend a little bit of time talking to people, how do you feel about it, how do you feel about the response of other people to you, given that you have this, how do you feel about the treatment opportunities, options out there that we've talked about. Because when you do it, you want people to do it right. It's like anything else that it's not rocket science, honestly, but it's a lot of repetition and practice and iteration, doing the same things, learning about yourself as you go, shaping the treatment again with the data that you get, and it requires the person being on board and making it a priority. The expectations for treatment, of course, any of us would want to be cured, and never again to experience an urge, never again to pull out a hair. For most of these disorders, it's more appropriate to think in terms of managing it. And when I say management, somehow I think people see that as not enough. But frankly, if you think of your health, we all manage our health. I mean, I manage back issues on occasion, and there's very few things that are like cured and done forever. I mean, maybe an infection is. We manage most of the things in our lives. So I think when people think in that perspective, it positions them well to understand that they may still have challenges over time. If you think that something's totally done, if you get triggered again, whether it's for OCD or for trick, and you thought it was done, you're set up to fail. Because either you'll say, well, the treatment didn't work because it came back. But if you understand that you may have to work on it again, just like most of us, you can go to the gym and you can improve whatever your strength. If you don't do anything for 6 months, you have to go back and work on it again. Okay, so for the automatic pulling, there's two styles of pulling that we talked about. For the automatic pulling, these are the things that we would do. We would try to figure out what precedes it, try to get people aware of the triggers, give them some strategies to cope with it. For the focused pulling, again, what are the antecedents? In this case, it's usually some inner experience. And there are probably different things that are required for people to manage focused pulling. The automatic pulling is probably the easier one to address. So the core treatment elements generally psychoed for all of these disorders, so people really understand what it is, what it isn't, right? I think that gives people a sense of power. If we need to, do some motivational engineering to get people on board, ready to do what they need to do. Then we do the self-monitoring, so you saw that log. And then the very next thing that we do is stimulus control. And I've got some slides on all of these things, but from stimulus control down, these are, the elements that are really going to make a difference. These are all the coping strategies that are going to help people to reduce it. So what is stimulus control? Stimulus control is just changing things in the environment so that something is different between the sites that the people pull from and the hands that they pull with. So the very first thing, though, that we try to do with people is to do things that will help to increase their awareness if they're not aware. If you're not aware, it's a foregone conclusion, right? So you need to have it into a choice realm for individuals. So there's just a number of different things that are simple. So if somebody tends to do habitual pulling when they're watching TV, have them put a Post-it on the TV, have them put a ribbon on the steering wheel if they pull in the car. If they try to do, if they do transient pulling, set your cell phone timer, set the timer on, your desktop at work. For some people, having a picture of their themselves with no hair loss is motivating and keeps them more aware. If it works to have someone in the environment to cue you if your hand goes up, I mean, that can backfire, right? But if you set some good guidelines on how to do that. So to try to establish that awareness, so it's a choice. Is the person going to pull, or is the person going to choose a different coping strategy? So there are a lot of different things that trigger people, right? So we're talking about mirrors can trigger people if they see hairs that are abnormal. If people are touching their hair and the tactility doesn't feel right. So these are different things that people choose to do to limit the triggering. So people can cover mirrors so they don't have mirrors everywhere they go. They can dim the illumination in a bathroom. Some people choose not to carry like a makeup mirror so that they're not constantly looking at their eyebrows, their eyelashes, wearing Band-Aids, wearing hats so that you're not feeling your hair. Even putting a hair product in can change how your hair feels. Just changing body posture, like a lot of pullers would sit like this on the couch, right? That's not so good. You're pulling from your hair. You want to, sit straight up so that you just don't slip into the, the tactility and the pulling. For somebody that tends to pull at the end of the day, maybe they shouldn't be sitting in their room. If they're a student studying, maybe they should study in the library. Maybe they should study in a more common area. Behavioral alternatives. So if you remember, we talked about with the habitual pulling, very often it's under conditions of reduced sensory stimulation. People are bored, they're antsy, they want to fidget, they want something to do with their hands, so you need to provide something other than their hair. So whether it's silly putty or those push balls with all those projectile strings or yarn or those wacky tracks, bubble wrap that they can pop, pipe cleaners that they can bend, people that have pets to brush the pet. Rare cases, I've had people pull hair from pets. I mean, you want to ask that question, make sure that's not an issue. I've had who's pulling by proxy, and there are people that can pull hair from their kids as well. So, that's not that common, but you want to make sure that we're not going down that path. But something to do with the hand, preferably something that could be functional, but at a minimal, it's not destructive, right? Or just hobbies. If you're sitting in front of the TV, you could be knitting, you could be beading. So very often you need to have people just try things out. This may work in this situation, but it won't work in that situation. A good example is students, very often I have a lot of parents saying, what do? My daughter wants to wear a hat to school because she's had a lot of hair loss and the teachers make her take it off, and then the kids, tease and taunt her. So hats sometimes work outside of school. The kids hats do not work in school, and you need to do something else. You need to be creative. You need to go through a lot of different suggestions. Competing response. Competing response is doing something, a muscle or muscles, that's incompatible with pulling. It could be holding onto a ball really tightly. The easiest thing that requires no prop is making a fist and holding it for 90 seconds. And if any of you try it, seriously, hold it for 90 seconds. To me, it was akin to holding a tennis racket for any of you that played a sport and had to hold an instrument tightly. By the end of it, your hand just feels like jelly, like you don't want to be doing fine motor manipulation. So we talk to people about engaging in a competing motor response anytime that they've been pulling, or in fact, anytime that they have an urge. It puts a little interruption, right, with a delay of gratification, and sometimes the urges, they come and they go, they start to dissipate. And in that interval, there are times where people are able to generate for themselves, this is a different way that I can go. It's that little choice point, breaking that impulsivity. I have the urge pull. So those are the things that are considered to be the standard for the more automatic or habitual pulling, the stimulus control and the competing response. So historically, when we've tracked people and done studies, before we really knew a lot about the styles for pulling, what we found was that not everybody got better. Those that got better didn't always reach full abstinence, so they didn't totally stop. And then over time, if you tracked people, the maintenance of the gains dropped off, so the symptoms started to come back. So that got a few of us thinking about, we need to augment our treatments, and how are we going to augment it? So pretty much what most people are thinking right now is that traditional CBT, all that stuff I talked about, the competing motor response, the stimulus control, the fidget toys, the blockers, the cuers, that's probably more effective for the automatic pulling, the overlearned habitual pulling. But maybe we need to do something different when somebody is emotionally, aroused, when sensorily they feel really deprived or dysregulated, they're in pain or something else is going on. So myself and Doug Woods, who's in Milwaukee, soon to be in Texas, he's moving down to Texas for another position, augmented the traditional treatments. I use something called DBT. Is that familiar with most of us? DBT? Yes, good. And he used something called ACT, or ACT, which is maybe a little bit less known. Anybody know what ACT is? Oh, good, cool. So both of these are different ways to try to get people to manage uncomfortable inner experiences. In ACT, acceptance and commitment therapy, the concept here is that a lot of these dysfunctional behaviors reflect what we call experiential avoidance. So something's going on internally, it's really uncomfortable, people have no ability to tolerate it, so what they do is X, they drink or pull out their hair. With DBT, they call it more affective dysregulation, and in both cases, we believe that if we get people to be able to manage these inner experiences better, that probably the focused pulling is not going to be as problematic. So in the DBT enhanced HRT, we used a lot of the techniques that come from dialectic behavior therapy, and this is this amalgam of treatment strategies that was originally designed for people that have problems with impulsivity and something that's called borderline personality disorder. But with time, we realized that these techniques can be effective, with a large number of disorders of impulsivity. It's been used for eating disorders. It's been used for drug addictions. So I'm using it here. I used it for TRIC, and we published the results, and that was helpful. So one of the first things that we do is we teach people mindfulness. Hopefully everybody has some sense of mindfulness. So teaching people how to be more present in the moment, on purpose, non-judgmentally. And we thought this was going to be helpful for TRIC because if you're more present, you're going to be more aware of your inner experience. You're going to be more aware if your hand moves towards your head. If you're in the moment, you're not as likely to be worrying about what happened last week or worrying about the future. And when people have mindfulness skills, very often they can tolerate discomfort better. So this was one of the modules that we used. We also used a lot of the emotion regulation techniques from DBT, and it is what it says, is teaching people how to manage uncomfortable emotions more effectively, and in this case, more effectively so that they don't pull their hair. And these are just standard DBT things. They're things that help people, so reducing vulnerability to emotion when we're more likely to be emotional if we don't eat well, we don't exercise, we don't get enough sleep, we use drugs. Increasing positive emotions, we can all change our emotional life. I mean, there are things that we know make us happy, and we can engage in them, with a greater frequency to change our mood. Learning how to let go of suffering. I don't know if you folks have ever heard the distinction between pain and suffering. We all have pain in our lives, whether we like it or not. Suffering is that added layer that people put onto it when very often they don't accept what's going on. This isn't right, this isn't fair, it shouldn't be happening to me. And all you do is you just escalate, the intensity of what you're experiencing. So learning how to be able to let go of some of these things and not add the suffering to the pain. Opposite action is just engaging in the opposite of what your action tendency is to try and do emotional correction. I know we're running out of time, so I'm going to just zip really quickly through a few slides. Distress tolerance. Distress tolerance is how to get through something without making it worse. So it's what can you do if you're in a situation that is just very uncomfortable for you. You want to be able, it has a beginning point and an end point, and you want to be able to get through it without engaging in these behaviors. And it can be doing things like distracting yourself. I mean, when I think of this, whenever I go to the dentist, I sit there and I just do math in my head, or I count the tiles and the ceiling just to get through the experience. And, it works. Self-soothing, doing things that are sensory, listening to music, having smells that are relaxing, visual things that you find relaxing, tactile things. It could be something that's silky that has a connotation. Improving the moment, this is an acronym, and that includes I's for imagery, N is for meaningfulness or meaning. They all make lemonade out of lemons. And then it's a bunch of other things, prayer, relaxation, one thing at a time. But how to, very concrete strategies of how to get through uncomfortable experience. ACT. So ACT approaches it a little bit differently. For the same end state goal, the focus with ACT isn't so much teaching somebody specific techniques and strategies of how to reduce some of these uncomfortable experiences. It's more a philosophy of we're going to have these things, and you can say I won't tolerate it, or you can say I'm going to accept that I have these uncomfortable experiences and not try to avoid them. And by doing so, by not avoiding them, I'm more likely to reach my goal, right? So it's trying to get people to think, what's important to me? Valued living. What are the things that I want to accomplish? What's in the way? And it's getting people to realize that some of these dysfunctional behaviors, in this case, Triptylmania, the hair pulling, is a behavior that they're engaging in so that they don't experience this inner discomfort. These are just different ACT techniques that are used, and this is a workbook that Doug Woods and two put together. There's books on it if you want to read about it. Just a few other things to say, and I'm pretty much done. It may be the case that combining medication and CBT will be superior. There have been a lot of studies. We don't know with medication and CBT if you should do one first and then the other. You should kind of double barrel it. That's another question that we have to figure out. In terms of medication, there's no FDA-approved medication for this disorder. There's a number of double-blind studies that have been conducted. Long ago, people looked at clomipramine, and they showed it to be superior to dicipramine. That's a medication people don't prescribe that often. People looked at the SSRIs, some conflicting results with it. In some studies they get better, and some they wouldn't. Probably their samples were different, their measures, their assessment measures were different. More recently, people have been looking at different classes of drugs. So opioid antagonists, so drugs that are used for drug addiction, following on with that addiction model. So naltrexone is something that has had some benefit. NAC, N-acetylcysteine, which very interestingly is used for clearance of hepatotoxicity. So if somebody has a Tylenol overdose, this is a medication that's used to clear their liver. But it also works on certain neurotransmitters that are believed to be implicated in this disorder. Olanzapine is an atypical neuroleptic. So there's some benefit for some people with some medications, but it doesn't seem to be as widespread as the CBT. There may be different subsets of this disorder that we still need to parse out, and to know that for this clinical configuration presentation, this is how you should proceed. This algorithm for this one you should do. So just to wrap up, it's a very heterogeneous disorder that many and different trigger consequences that can vary over time for different people or the same person. Right now, I think everybody that is involved in research or clinical treatment of disorder would agree that CBT is first line. Medication may help. It may help by treating a comorbid disorder, which then gives the person the resources to be able to do the CBT. The traditional CBT that I was talking about, this, the adverse reversal and the stimulus control, can definitely work to reduce the pulling severity, but not everybody benefits just with that, and maintenance of gains has been an issue. So trying to augment traditional CBT with some ACT acceptance and commitment therapy or DBT behavior therapy tools may be necessary, particularly when some of these presentations more focused than automatic. And it may be the case that dual modality treatment combining the two ultimately may be more superior to just doing the CBT alone. If you folks are really interested in learning about this, this is an edited text that a number of us put together that came out last year that talks about all the different body focus behaviors, and it's kind of the latest compendium of methods. And I think that's it. Do people have any questions?
I think Churchy was habit reversal therapy.
Yep. Yes?
What is ETOH?
Oh, alcohol. I'm sorry.
Oh,
That's the
okay.
abbreviation for alcohol.
Okay.
Okay. Well, listen, you guys have been a great audience. I know. Yes.
Would I be able to